Yeah, no, even though we have new therapeutics, we still are retina surgeons and we're going to talk about surgery. So today's theme, I was expecting one thing and then something else happened during surgery. Again, thanking our friends at Bausch & Lomb for their support for Cobra and the continued support. We'll talk more about future Cobra programs in a few minutes. Prithvi, take it away.
Yes, so let's keep it interactive. The chat is open. We learn more from the chat sometimes than from me and Sunil, which is always a good thing. And we have not only awesome fellows presenting, but we have superior faculty members that are going to guide us through this. So our first case presentation is from one of the first-year Stanford Vitreoretinal Surgery Fellows, Karen Way. Karen joins us from Boston, from the Massachusetts Eye and Ear Infirmary. And she's going to be presenting a case that she has done with Rams Nirala, who's one of our attendings on the retina service. And our faculty mentor from Stanford is Dr. Stephen Smith. So Stephen, Karen, take it away.
Hi, everyone. Thanks for having me. And I'm really lucky that I have Rams right next to me too.
Hello, everyone.
So my case here. So this is a 44-year-old female. She's had a history of PDR in her left eye. She came in November with a new bleed in her right eye, conversion to PDR. At that time, she was given her first Avastin. She was about 20/80 at that time. She came back in a month later, and she was found to have inferior TRD-RD along her inferior arcade. Was given a second Avastin in preparation for surgery. Her acuity, she's 20/40 in the right eye and 2300 in the left eye. She's had a previous VIT and MVG in that left eye. And then of note, she's pseudophakic in both eyes. So here we kind of enter in the eye. We're able to see this white fibrovascular plaque extending along the inferior arcade. Our main goal here right now is to take a look around and separate any anterior posterior traction. She has a little bit of heme remaining as well. As we are kind of looking around, we kind of see superiorly, there's another pocket of fluid here. And this was our surgical surprise. She has a second localized RD right here with 2 small holes supratemporally.
Hey, Karen, can I ask you a question? Did the retina look different to you? Besides the detachment, did the neovascular membrane that you see or the fibrosis look any different in the eye than it did preoperatively? Like, do you think was it much more vascular before surgery or before the injections?
Yeah, so I actually had seen her in December before her or during the time of her second injection. And I think the fibrovascular membrane looked pretty similar to how it looked during surgery. But the second retinal detachment superiorly was something new.
When we ran an OCT through that area, there was like minimal traction there, which is why we gave that Avastin. But then it crunched and caused the TRD-RD.
And then another question, was there any thought if the view was good enough of putting in some PRP before you went into the eye? Again, I can't remember how much hemorrhage was there? Was there so much that you couldn't see or was there any discussion about PRP?
There was, to be honest, there wasn't a ton of hemorrhage. She was 20/80 when she first presented. So that certainly would have been a good idea and maybe would have, helped us, more so in the future. But I think, especially given her plans to go to surgery, we were planning to do PRP intraoperatively.
Sure. Yeah.
So this was done at our county hospital, and are there considerations? We always worry about crunch or too much time between injection and surgery. Is there a consideration in that patient population where you wouldn't preoperatively give an anti-VEGF injection? Like, do you normally do that in that population?
Yeah,
and I guess
that's
Cleveland crowd, your county, same thing.
At least here, I found that like the compliance with actually coming to surgery is actually better. So we've been giving pre-op Avastin, and then if they fall off, I just bring them back immediately, just to monitor them closely, and then I rebook them for surgery as soon as possible. But I haven't had that issue so much here, actually.
And
But yeah,
when
in
you say
general-
pre-op, what sort of time frame? Is it like a month before, 3 days before, 5 days before? What do you try to do kind of as your typical protocol, I guess?
It's typically like 5 to 7 days before.
Yeah, I'm at our county here in Cleveland. I am a huge fan of preoperative anti-VEGF. I use it often. Obviously always concerned about crunch or the theory of crunch, but having operated pre anti-VEGF days, I will take crunch over not you having it any day of the week. And I'm become more and more a believer of multiple anti-VEGFs before tackling some of these complicated TRDs. I think it really makes a difference on control of hemorrhage, which I think can be a challenge, especially if some of these patients are hemodynamically unstable. And Kat brought up a point about medical clearance. Some of my worst anesthetic cases have been in diabetics who aren't medically doing well. So it just gives me time to get their blood pressure under control and some other things. So I tend to space things out, and I don't mind using anti-VEGF a couple of times.
I also find that it's easier to like peel the membranes, especially when they're like tabletop TRDs. It's much easier to kind of release those fibrovascular membranes after Avastin.
Yeah, no, I agree. I think more anti-VEGF in general, the risk of crunch to me is less than the actual occurrence of worse bleeding during these cases, intraoperative issues. And so I like more Avastin. And then when you can, I also really like if you can get some PRP down. That's one of the reasons that I asked, because if you got that extra stability, I feel like it's almost it's not quite like another hand, chandelier, kind of two-handed, but it's almost like having another hand when you've got, good PRP. And so when I can, if I have the luxury of a little bit of time, I try to get the PRP in too before I go to the OR.
So this was brought up in the chat. Somebody said 1 week is too long. They do 48 to 72 hours. A couple people have mentioned a couple days before. Some people have said a week before. What time frame do you like to give it? And is there any data that talks about it?
So based on, I usually do 5 to 7 days because I feel like, at least from my experience, like 48 hours, they still bleed a lot. So that's why I give it a little bit earlier.
Yeah, I do too. I like the 5 to 7 days a lot. I think that there was a study that showed that at 48 hours, there wasn't much in terms of modifications to the vessels that's happening. You don't really start to see that until day 4 or 5. And so I like the 5 to 7 days before for that reason.
I think it's also, quite honestly, if we all agree within 7 days, it's probably the convenience of whether you saw them the week before clinic when that is. So that's, I think 2 days is probably not enough for the impact that we're all looking for. And the concern is that you do it and then they don't show up for 3-4 weeks. But then again, maybe they're nicely dry by that point, then you have to deal with it. So, Stephen, I think Dr. Hartnett, who welcome just as a new addition to the Stanford faculty, had some probing questions. Stephen, do you want to address that? She's not sure about this surprise detachment, how it may have shown up.
Yeah. So I certainly think, I'm just looking at the chat. I just pulled open the chat right now. Hey, Emmy, great to have you here. Was a break superiorly as a small humor hole? Karen, can you comment on that? Did you find, if I remember correctly, you said there were some holes that were identified. Is that right?
Yeah, there's a hole. You can see right here in this cut, right underneath the retractor, there's a cut hole right there. Yep.
And so where in the valley are injections given? Is this possibly a complication, secondary to an injection? I assume it's not, but do you guys inject supratemporal? Where do you give the injections typically?
Yeah, so I actually know because I injected this patient. So I always inject infratemporally, but it was definitely a thought that ran through our head.
Yeah. So I guess your thinking would be that this was just vitreoretinal traction. Is that correct in terms of what caused this hole?
That's what we're suspecting.
Yep. And that would be my assumption too. And then, I think one of the other considerations, because we're talking about surgical surprises, is, what is the role of pre-surgical evaluation, right? Throwing on an indirect and taking a look ahead of time. Now, in this case, again, I've had the luxury of looking at the whole case start to finish. I don't think it changes anything, right? But I think there are circumstances where maybe it does. So, thoughts from you, Karen, and Rams too on how frequently you do this, the value of it, and other surgeons as well. Just kind of, I guess, a discussion point is, how typical is it? We're seeing patients, we see them a week before surgery, sometimes 2 weeks before surgery or more, right? And how common is it of a practice to actually in the pre-op area put on an indirect and do a repeat your dilated eye exam?
So one of my attendings at Mass Eye, Dr. Elliott, actually always made his fellows look beforehand, which I think is probably a good habit to get into. I think in this particular case, especially if that retinal detachment had been inferior, I think it would have been good to maybe consider a buckle as well. I think someone said that in the chat too. But I think we were, frankly, a little lucky in this case that it didn't change our overall surgical plan.
Mm-hmm.
I'll just say that, if you're a fellow, since it's geared to fellows, and you're lucky enough that an attending is letting you operate, congratulations. You should be looking at each of these patients preoperatively. Most importantly, to make your own surgical plan in order to decide what to do. So, part of the whole experience is probably figuring out or coming up with in your own mind of what the plan should be. So you can certainly sit there and listen to the attending tell you what to do, but I think looking and coming up with your own surgical plan is a really important aspect of your education. So I strongly encourage, if you haven't met the patient beforehand, throw on the indirect. It's also time for you to make a connection with the patient. So it's a really good idea.
Yeah.
So there's a question here about buckles and diabetics, and I think that maybe that's a point that we can discuss here, especially in the setting of like this situation where something's come up. Do you buckle? Any thoughts from the panel on this, Kat? What's your take on buckling a diabetic TRD? That maybe let's just say that there's inferior tractional disease that you see there, and kind of either preoperatively or intraoperatively making that call for a buckle.
Yeah, I mean, as our fellows know, I always say I hate putting on a buckle once I've started doing a vitrectomy. So once the ports are in, I really don't like to put on a buckle. I'm not against putting on a buckle in a diabetic in general. I have to say though, in some of these like combined TRD, RRD cases, I think I gravitate more towards just doing a straight vit as opposed to doing a buckle, because I find that often the breaks are due to sort of traction of the vitreous and from the fibrovascular plaques, and it's a little bit of a different mechanism than some of our just straight rhegmatogenous ones. But now that we're having this conversation, I'm wondering if maybe I should be thinking about that a little bit more. But in most of these cases where they're combined, the breaks end up being more posterior than I feel like would be necessarily helped by a buckle.
Yeah, that's my thinking too. It's often the pathology is posterior enough that you don't get a lot of benefit out of the buckle. I love buckling for RRDs, because I feel like it gives patients the best chance of success on the first surgery, or sometimes when they're referred in and I'm their third surgery, it's the best chance. But for TRDs, I really typically, it's rare for me to even consider putting a buckle on. And in this case, if there'd been a pre-op exam and I had seen the holes where they were, I probably still wouldn't have put a buckle on this eye. Now I would have wanted to do a good scleral depressed exam and convince myself there was no other pathology inferiorly. Inferior holes would have maybe changed that calculus a little bit, but I wouldn't have buckled this, and I wouldn't have, if I was in the middle of the case, I wouldn't have even considered putting a buckle on based on how this looks personally.
I think the other eye had neovascular glaucoma, is at risk probably for ischemia, just given the history in the other eye. And the holes to me sometimes predict that your tractional element of the hyaloid is probably pretty taut. You could probably go either way, but in general, if given that history in the other eye, I probably would avoid it, especially since you're going to be probably putting on a fair amount of laser. That said, if the hyaloid doesn't come up off of those breaks, I think you're obligated to. So I think it would depend on if the hyaloid comes up. So if the hyaloid comes up, you're probably okay, but if it doesn't, you have traction, you may want to consider it.
Mm-hmm. Another good question in the chat was, thinking about doing an EUA or PRP on the other eye, and when what sort of circumstances do you take care of both eyes? And I'll throw that out to Karen, I guess your thoughts, and then other faculty on the panel as well. What are thoughts on when you take care of both eyes?
I guess in my limited experience as a retina fellow, I definitely think it's a good idea to try and get both eyes as soon as possible when a patient presents with complications in one eye. I think being aggressive, I don't know if it's, whether or not it's intraoperatively or, in the pre-op or post-op period, to try and get some PRP in the other eye, I think is really important.
In this particular case, the other eye was vitrectomized already and already had 360 endo laser PRP. So
let's get back to that one. Should we continue with the case a little bit and then come
Yes.
back?
Okay.
We're doing pretty well. We only interrupted you at 38 seconds. That's pretty great for Cobra.
So we put some catalog in and then kind of talk about the ways that, we're gonna approach this fibrovascular plaque. First here, trying to use the ILM forceps to see if we can get an edge to start kind of segmenting and peel off this plaque. It's not too successful. And then here we're going with the vitrector to see if we can segment part of it. We're having a little more luck here. And then going back in with the forceps and seeing if we can pull anything, but it seems pretty taut and, kind of very adherent and quite floppy. And then we also, kind of, given the difficulties with removing the plaque, we also tried higher mag with the drop-on lens. And I know the view is not great here, but we're pulling with the vitrector and then the ILM forceps here. And then shortly, we're going to switch back to the recite. And you can see we're making very slow progress with this plaque. Dr. Narala watched me probably for like an hour kind of pull at this
No.
until she very nicely suggested that we switch to bimanual technique using a chandelier, which was really, really nice. And we'll show that in a minute. Yes, I have the best timing.
Even in these moves where it seems like it's frustrating because you feel like you're not making progress, you're understanding the anatomy. So I don't think anyone here is going to kind of criticize you for, taking your time. It's a good thing. It's okay. Understand the anatomy, pick the tools that make you successful. So you're good.
Aaron, you said that this is a combined tractional rhegmatogenous. Where was the posterior break?
Yeah, so it was kind of in the area where the light is right now. There's another break kind of in this area that's very crunched up. Here, we're using the lighted pick. This was my first time personally using the lighted pick, and I thought it was a really nice tool to help dissect off this plaque. I really like the bimanual technique and being able to have a little more counter traction, being able to kind of pull on the membrane with my left hand and then using my right to kind of help segment and remove this plaque off as gently as possible.
Karen did a great job.
And
Did you consider other instruments in your other hand?
Yeah, so when we get to good spots, Karen, you let us know when you're ready, and then I think we can discuss, because instrumentation, I think, is one of the things that we can have a discussion on. Maybe once you finish, so you can get the plaque the rest of the way off, and then it'll be.
We're almost there. It was a lot longer in real life.
It's supposed to be.
I think this is it. Yeah, I can see the retina is nice and bolus now, and the traction has been released.
Yep. Great. So yeah, so why don't we pause there?
Did this connect with the superior detachment as well? Did this, or is this,
No.
where are we?
I'm not sure if you can see
That's
my
still up there.
cursor, but this is
Yeah.
the extent of the inferior TRD.
Okay,
artery.
sorry.
Here is the
That's very well.
separate artery.
Yeah. So I think this is a good point just to discuss kind of instrumentation and then thoughts on number one. So for example, you started peeling with the ILM forceps, and Karen, as we were chatting about this yesterday, I think it was briefly, I asked why ILM forceps, why not serrated or max grip forceps? I guess thinking about instrumentation and how you're peeling membranes, especially TRDs, super adherent, spongy is kind of how you describe membranes like this. What's your thought process in terms of selecting instruments and how you approach these cases?
Yeah, I think certainly serrated forceps would have been nice maybe to get a better handle on the membrane that you're pulling off. But I think initially going in with the ILM forceps, I felt that they could be a little more gentler on the membranes, especially as someone who has maybe a little less experience than my attendings in terms of pulling off the membrane. But I think in retrospect, and especially now watching the video, maybe going in with a serrated forceps would have been a better idea.
Yeah, I mean, I don't know that there's a right or a wrong answer, right? I think it's whatever works, and that's one of the fun things about the art of surgery. So I don't think you did anything wrong, but it's something to consider. Typically with more adherent membranes like this, you get just better purchase, obviously with a serrated forceps, and less likely to have it to lose your grip, right? And so, but I also find that in the modern era of retina surgery that we do use the cutter a lot more than just forceps, even though it's often easy to grab these membranes with serrated forceps or otherwise. Often when you pull, you're going to rip, large holes. And so the role of the microvitrectomy handpiece, I think, is, more central now than it used to be, 15 years ago before I was operating. So.
I used to use max grips a lot when I would do like TRDs, and then I switched to ILM forceps because some of my colleagues were using that more. And I just feel like I know it's not as controlled in terms of like, you don't get as nice of a grab, but I feel like it was gentler, and I still could had good control of the membrane that I was grabbing. So I think it was because of me that she used ILM forceps, because it's more of a preference thing. Yeah.
And again, I don't think that there's a right or a wrong answer. It's just thought process, right? And for a lot of that. And then what I guess triggered the switch to the chandelier light source, and when do you make that switch? Kind of help us. How long, I guess, before you pull that trigger?
I think I was just seeing that it was basically like a tabletop. There weren't any great planes to kind of work with. And I could see that the retina was very thin as well. And so I was worried that we were going to make iatrogenic breaks. So at that point, I was like, let's just switch to bimanual. It's just easier when you have two hands to kind of dissect these tabletop TRDs off the retina safely.
Mm-hmm. And a number of comments are discussing curved scissors. And so just maybe walk us through thought process when you might use these, if you use them a lot, right? I think that there are some instruments that we get more comfortable or less comfortable with. So thinking about, use of curved scissors.
I personally have not used curved scissors, but I know one thing, sorry, to shift the topic a little bit, that I keep seeing in the chat as well as, intraoperatively, we kept talking about how we wish we had a 27 gauge cutter too, to kind of more finely dissect the planes, just because in this case, we only had the 25 gauge, but I think having a smaller mouth to be able to kind of tuck under the areas of the plaque would have been nice to have.
Mm-hmm.
No, I think the curved scissors is great as well. I've had more success with the lighted. I've just worked more with the lighted pick. So that's what we went with.
Mm-hmm.
But curved scissors work well too.
Prithvi, what are your thoughts? When do you use curved scissors? I guess for these bimanual cases, how do you approach these when you're kind of in the eye or preoperative?
I think one of the concerns is that people don't consider bimanual surgery until like they're in the midst of things, and then it's too much of a issue to kind of change mid-flight. I would say that if your interest is to become a good bimanual surgeon, these are the types of cases that you at least kind of plan for it a priori, like knowing that it's going to be complex. And if you got a view of the fibrovascular membrane, you might be very lucky, but this is one where you you hold the instruments ahead of time. Even sticking a chandelier just to start with in the training setting is probably not wrong. I mean, you'll still get great visualization. If everything just peeled off with one forcep maneuver, great. But this way you're already set, you're ready to go. You're not like having tugged, as Karen said, for a while and then deciding to change course. So I'd say that the instrumentation, you can go either way. I love the fact that we had the lighted pick in place, and then you switch to forcep and vitrector. All of that is trying to be gentle and careful on the retinal surface. But I think having started the case with a chandelier in place, telling them to have the lighted pick available and a scissors and a forcep for the next time you do this will kind of make you more prone to trying to use both hands, or else you'll just never do it. You'll just sit there, with one hand pulling or trying to use the cutter and make a hole and make some decision like, okay, I'll make a hole in the retina and take it out and laser it at the end of the day anyways, and you'll regret that. So I'm okay with the scissor, I'm okay with whatever, but almost like do it a priori, especially in a training setting.
Yeah, great. All right.
Okay, let's finish up this case
Yep.
so we can move on to the next one. Sorry to keep you guys moving.
Yeah, so now that you can nicely see the posterior break there. Retina's looking a lot better, diathermized. Making sure there's nothing else going on in the superior RD. Put in a little more Kenalog. Doing a good peripheral shave and peripheral depression. Marking our other hole that we saw. And then we use PFO here to flatten.
And you're flattening the PFO over the posterior break. So where are you draining from then? Are you draining from those superior breaks, even the inferior detachment? Or did you create a peripheral drainage retinotomy? I don't quite understand.
We ended up draining from the superior RD and then just from the posterior pole. So we'll show that here.
So you kind of made almost a total RD then, and because the fluid had to go all the way around to that area, right? Because you could have just drained with under air through that posterior break.
Yeah, we could have. And then the other breaks were really anterior in that superior localized detachment. But yeah, that makes sense.
Yeah, I mean, if you still had some traction on that posterior break, I wouldn't put PFO in, because that's how you end up with a whole bunch of subretinal PFO too. I mean, you had two options there. You could have drained and done any of the PRP that you can before going to air, so any of the attached areas, and then drain the posterior break, and then drain the peripheral stuff with air and laser it, like Steve said. And I actually think that's probably safer in this situation. You may end up with some residual fluid in that loculated, but you don't cause more RD from just pushing the PFO and causing all that fluid to try to go around.
Yeah, I think that definitely
Yeah,
would have been a good idea.
It's not wrong what you did,
No.
but I think it's another point.
We essentially applied 360 PRP here. And she actually looked really good at the end. And then we ended up closing with C3F8. And we just have 1 month of follow-up, but
she
she's
came back.
Yeah, for her 1 month. And then she's still attached. Her vision's 2100 with, she still has 50% of her gas left.
Great. Awesome. Time for a couple wrap up here. Do we have, or I know we have another case. So I guess a few key things that I took away from this, I would say, fellows, it's always a good idea to look at patients before you operate on them, especially if you haven't seen them before. Even if you have seen them before and there's time that's passed, always good to take a look. Anti-VEGF is your friend with TRDs. And when you're a fellow and you can do bimanual technique and you have the opportunity to put in a chandelier, it's always great to it's always great to do that. The other thing that we could have discussed is gas versus oil in this case. Again, I don't know how we're doing for time. Do we need to?
Why don't we
shut
move
it
on to
down?
the next one, Steve? We got 3 more cases to show.
Okay. All right, we'll move on.
Thank you.
Thanks,
Thank you.
Karen.
Great case.
How do you up next?
Yeah, so our next presenter from Cole Institute, no, it's gonna be Leanne. Leanne's gonna go.
Oh, Leanne's gonna
first,
go,
yeah.
sorry.
Yeah, sorry, Leanne
Thanks for making
Clevenger,
my-
Leanne. Yeah, we'll make sure that you're set up. So
How do you best
Leanne-
clean up?
Leanne is one of our first year fellows that did her residency here at Cole Eye, and Sumit Sharma is going to be our discussant. Take it away, Leanne.
Awesome. Can you guys see my slides here?
Yes.
Yep.
Awesome. So my patient is a 93-year-old female. She was referred to us with a macula off retinal detachment in her left eye. She's been symptomatic for 3 weeks. She does have a history of cataract surgery in both eyes. She has hypertension. She's only on baby aspirin, along with other antihypertensives, simvastatin. She lives with her family, but she's, fairly ambulatory functional. She has otherwise intermediate dry AMD in both eyes. And she, again, is symptomatic for just 3 weeks. So she is LP in this left eye versus 20/50 in the other eye. She's known to have an APD, and we don't know her prescription from prior to cataract surgery, but we don't know that she's especially myopic either. She's like -3 in both. So anterior exam otherwise unremarkable other than being pseudophakic. And in this left eye here, we know that she has a near, pretty much 360 RD with superior breaks that we can see, but areas of kind of ratty looking retina that are suspicious for more micro breaks, and pigmentary changes on the retina concerning for early PVR, but no, extensive PVR that we could see. So our plan was in this eye to do a buccal vitrectomy, likely C3F8. So let me see if I can get the video. All right. Let me know if you can't see it, but at this point, we've already gotten the buccal onto the eye. We use a 4170 band. We are, starting the case off, and it's hard to appreciate kind of in the video, but early on in the case, the eye did become hypotenuse, so the kind of the walls are infolding on me here. And we did, proceed best we could, kind of cleared around the infusion to just make sure that the eye stayed pressurized. Tried to, make our way around, identify any other breaks. Did find, some more breaks inferiorly as well as superior breaks that we'll get to as we're clearing. Tried to drain some from this inferior break here, and then, did notice at this point that what looks like a choroidal is starting to develop, in the infratemporal quadrant here. So, this is concerning. At this point, we're, wondering if, there's any, sorry, can you guys see the video? I just want to make sure it's actually playing.
Yeah. So why don't you,
Okay.
so this is your surprise, Leanne. Why don't you take us through what you were
Yes.
thinking at this time?
Yeah. So
Besides
this
sweating
point,
a lot.
other than, oh man, I'm thinking that I want to make sure that the patient's blood pressure is not overly high. So we looked up, made sure she's in the 140s to 150 systolic at this point. She's comfortable. She's not bearing down, in distress at this point. We want to, we'd already put a buckle on. I didn't think that any of the passes were especially deep. But that's one thing we wanted to check for sure, was to make sure that the site of the suture pass was not, too deep. And then also to make sure that our infusion was in the correct position. So, just making sure that it hadn't slipped and gone, suprachoroidal. So it actually, our suture pass mine was so shallow that it actually had pulled out. So at this point, we just replaced it. We didn't, find any evidence for kind of a leak or from a deep suture pass here. So one of the things we had debated when we talked about this case later on was, would anybody have done, anything with the buccal, remove the buccal, even if they started to see this? But we thought that the choroidal was relatively stable. So we decided to kind of proceed with the case. It didn't seem to be progressing.
We added PFO at this point, kind of shaving around our
So
superior.
Liam, stop,
Yes.
stop for a second here.
Yeah.
Let's go back a minute.
Yeah.
So, okay, so you did, the first thing you did is you checked the infusion, right? So
Yes.
when did you first notice it? Because when you first said you noticed it versus what was on the video was a little different, right? So if you go back to where it was infolding, right at the
The
beginning.
infolding of the eye or the
Yeah.
choroidal?
The infolding,
Yeah, so-
right? So
oh,
you can already
definitely.
see a hint of the choroidal there before that even happened. So when do you think it actually happened?
It's hard to say. I mean, you're right. Like looking at it now, it does definitely look like it was
It
already
looks like
kind of
it's there,
starting.
even before you're infolded, it's there, right?
Yeah, looking at the case now, you're definitely right. You know, I definitely a deep scleral pass is always, I'm definitely suspicious for that. But, you know, again, it was so shallow, it had torn out. So not really sure at this point. We just wanted to make sure.
So what
that,
else could it be? So deep scleral pass, what else?
Yep. Slipped, cannula, making sure that the infusion hadn't gone into the incorrect place there, which we'd already seen it. So, that doesn't make any sense.
Okay.
Just making sure that the buckle wasn't too tight over like a, vortex compression kind of different area there.
So did you visualize the vortex in that quadrant? Because I knew you went back and looked at the buckle, but did you? I know Sunil's shaking his head, but
I don't.
nodding.
Yeah, I don't think that we did.
Yeah,
Necessarily.
no, that was part of the reason we looked, was to look at, see if the vortex was compressed.
Yeah.
And the vortex wasn't. And when we were, where it happened was when we became hypotenuse, right at the beginning. You can kind of see it. The eye just collapses in, and there's a hint of it in the beginning, but still was surprising because it got larger as our case was going on. So that's when I think we started looking around. So the first thing I do is I turn my head and I look at anesthesia, and I started asking the patient, "Are you feeling anything? Are you in pain?" She was awake during the surgery. She was comfortable and didn't feel anything. So, she, as far as we could tell, she was fine. And Peter, no, she wasn't anticoagulated. Actually, I can't
Aspirin.
remember that. Aspirin, yeah.
Mhm.
And we don't know her refraction preoperatively at this point.
Yeah. Okay. So, and then you see it, and luckily in this case, it's pretty small. But what if it had been bigger?
Well,
What if it filled the whole
It gets
quadrant?
a little-
It will. I know.
Just wait.
I've seen the video, so I know, but don't ruin it.
Surprise ruin. Yeah. That's a good question. I think we did go up on the infusion pressure early on too. That was another thing that we did. We went up to 40 and kind of just stayed there for the majority of the case. I think at some point, if it's just obviously so large, it's, I don't know at what point it gets beyond where you just stop and come back up another day. I'm not sure what your threshold. This is my first experience with intraop choroidals. So
Leanne,
doing great.
this is a left eye, correct?
yes.
So why are you going in with the cutter in your left hand? Are you left-handed or right-handed?
No, we with Dr. Shrivastava and others will start with the cutter on the same side of the left eye or the right eye. If it's a right eye, we start on the right side. I presume to be able to immediately go clear the infusion right away because we're already there, and then just switch hands and complete the other side. But we always start on this.
I think your
this side.
presumption is correct, and I think that's a really good point. I think typically, if given a choice, a fellow will go to their dominant hand regardless of the eye. And I think that this is a good example of, my concern here is that there's a whole bunch of vitreous with a PVD that's just going right up that infusion line, and that's what's getting blocked. If you were going in with your dominant hand, which maybe you're right, and then you have to then access that infusion port, you're coming out, and then bad things have transpired in that moment. So starting your vit, if possible, on the same side as your infusion makes a lot of sense. And one of your first moves in this case should be to head towards that infusion side and make sure that port's clean.
Definitely. And also just not, at the very beginning, probably starting so heavy on the pedal would have been a nice way to start too. But yeah,
we were just excited to get started.
So excited. It was my first OR day. Dr. Shrivastava, so excited. You know, and at this point, again, just kind of clearing around. So I'll fast forward when we're putting back the PFO into the eye, and things have kind of stayed, you know, relatively stable. So we, you know, are again just shaving into the periphery, kind of clear all of the breaks. When I feel like at this point we start to think, you know what, this is starting to look larger.
Yeah, I was gonna say that. Would
Yeah.
anyone done anything differently at this point? I'm just curious. You know, so we were relatively stable, and then things start changing on us. Anybody would do anything different?
Well, so
Oh, great.
had you
Awesome.
raised your infusion
Quit
at all?
now. Like,
No, so had you raised the infusion pressure at all from where you
Yeah,
were? running at?
we're up higher now. I think we're living somewhere between 40 and 50. I can't remember exactly where, but I wasn't at 60. We went up a couple of times, but you can see our nervous perfused. When we saw it getting larger, initially I shot it up very quickly and it stabilized. It looked pretty good. And then we were living at a higher, and I dropped Leanne's vacuum. So that was one of the other things is, you know, I like tell the fellows they like living in fifth gear all the time. And sometimes it's okay to not drive the Ferrari, you know, 120 miles an hour and 20 miles an hour. So I dropped her vacuum down.
Yeah, and I cut out a lot of the video where we just sat for a while at 60, just kind of letting things stabilize too before we kept going, lowered it again. So I feel
No,
like at
but-
this point. Go
No,
ahead.
sorry. Prithvi, I was questioning if I had a Ferrari. I had a Tesla. Thank you.
At this point, you know, again, starting to notice that it is creeping around more inferiorly. Trying, you know, at this point, we're lasering under PFO, and we do go ahead with the air fluid exchange. And I feel like at this point, every time that we look back to check on the choroidals, they're getting larger and larger, which was scary kind of as our pressure gradient changes. You know, we know that this is kind of spreading around. At this point, it's nasal. PFO is still in the eye.
So Leanne, let's ask everyone on the faculty, what would you do if an air fluid exchange and the choroidals getting larger?
Call Sunil. You can take over for me. Get out of Dodge.
Actually,
Trying to get out
Leanne's doing a great job. I think I take over at the last drain, but I'm pretty sure I just let Leanne sitting in there doing it, sweating, and as with me. But you know, I was trying to come up with ideas here about anything different. We could have certainly closed at this point, left the perfluorine in. She's 93. You know, in my mind, part of the reason, you know, I did the buckle was that she had told RD I wanted to fix her once and not take her back. And I just, you know, at some level, I'm thinking to myself, I'd like to get this perfluorine out, but I didn't want to make her, you know, obviously put her at risk. But I'm curious if any other ideas of what to do. Same would you done anything differently?
Yeah, I mean, the only thing I would have considered is going directly to oil, because the air is compressible versus oil is not compressible. So if you really wanted to avoid it, you could have gone direct PFO to oil exchange would be the only thing you could consider doing differently.
You know, we actually, Leanne and I sat there and talked about that. My only concern of that sometimes is that you can get a relative, I think it's sometimes hard to control that pressure gradient with the fluted needle, but yes, it's fair. I think that's a fair thing to try.
But that's the only thing you can really do different. I don't think I would have left her with PFO in the eye. Because then you're coming back in a week, 2, rather than oil, where you can buy yourself time. And I don't really think anything's going to change in a week or 2 to avoid this situation. I mean, you could have moved the infusion, so you could have taken the cannula out of there and put it somewhere else to see if there's something at all that's causing you an issue. Hung-Ween's worried about an oil underfill with going to oil, but you know, you'd have the same issue with gas unless you use an expansile gas.
So you know, one of the things that's, you know, and Leanne brought it up, we checked that infusion line 1,000 times.
Yeah.
You know, we're constant. I mean, I think I looked at it, you know, I stared at the infusion line more than anything else, but it was exactly where it needed to be, but it's fair. We could have done that.
I mean, my guess is there's something that occurred when the buckle went on. I'm not saying it was deep, but there was either some manipulation, extra massaging of the sclera that just set this off. And I think you were against a clock from the beginning. And one of the other things to think about is that there's a reasonable chance tomorrow this pressure, no matter what you put in, is going to be ridiculously high, right? Like this poor lady. And that's one of the concerns, is that if you have oil, then it compresses. If there's gas plus increased hemorrhage, you just don't know what's going to happen overnight. I think that's the real concern here.
So Liam, what were you thinking at this time?
When's
Um,
lunch?
No. At this point, it seems like we know that the choroidals are expanding every time that we take PFO out. So we'd already made the decision at this point to take out the PFO. I think at this point, we even checked the other, inferior quadrant just to make sure there was nothing else, now that it had spread around more nasal. But I think just being fast about it, I think, at some point we switched because we know we just have to get it out all at once before it all compresses. Talking, back to your comment about pressure, we did give her Diamox intraoperatively, just anticipating that also. But yeah, that was another big piece I'll get to, is kind of learning how to manage these patients post-operatively, because there was kind of a lot that went into that.
And I
Did
think
you
all the
think about
comments in
taking
the
the
chat.
buckle off?
I'm sorry?
Sorry, go ahead.
I said, did you
Sumit
think about
asked.
taking the buckle off?
We didn't debate it at the time, or at least I wasn't debating it in my head, but that was something that was brought up after the case that we talked about, was removing it. And I think the reason, at this point, we thought it was probably more related to the initial hypotony rather than the buckle itself. So we chose to leave it.
Yeah, it's a fair point, Sumit. I mean, I think this was,
Yeah.
when we went around and looked at everything, you could have taken the buckle off, but at this point, I didn't think it was the buckle, but the compression of a vortex vein that I
Yeah.
just missed.
That
It
you're
could have
just not
been,
seeing.
yeah. And I think also more manipulation might be a bad thing here.
Yeah,
Right,
I
staying on
agree.
the, I think I did, I think everyone's saying it at the chat right now, and we did loosen it up a little bit. It wasn't as, I know it looks high, but it's the choroidal.
It's choroidal.
We have an amazing buckle effect right now. It's fantastic.
It's not what I was going for, but that's what happened.
But at some level, this was just like staying controlled and just, again, here you can see where we're looking around, but we're doing okay.
Ugh.
Yeah, so it just keeps going. Still a little bit of PFO in the eye at this point. And we did wait, like there's lots of times where we just stopped and, tried, it just progressed, right in front of us. So, we tried to get all this PFO out because we knew that it was just going to come right across.
I think that was my move.
Yes.
Yeah.
And there goes the nerve. Goodbye. But we did, try to get all the PFO out as much as we could at this point.
All the breaks are supported by the choroidal.
Yes, very much. Closed everything up, C3F8 and she came back post-op day 1 with.
So how'd you handle her post-operatively? Yeah, let's talk about what you did immediately post-op. Yeah.
So let me see if I can switch back. So the first day we anticipated that she was going to, have quite a bit of a high pressure, and actually it wasn't as bad as I thought. It was 34 after having had Diamox around the time of surgery. So we started her on, I started her max IOP drops, oral steroids, and less than half mg per kg dose for her. Along with our typical post-op drops. She had a hyphema, she had an inferior VH, and she was stable a few days later. We wanted to make sure that pressure kept coming down. It wasn't headed the other direction. So she luckily, came down to 14. We kept her on everything. At week 1, her pressure was still okay. We actually saw her nerve at a week. She's not, vision's not getting any worse. We're starting to taper her pred. And then actually at a month, she's 2,300. Her pressure is doing okay. She still has a little bit of choroidals. They're getting better. But this is the last that we've seen her, still with about 40% gas in the eye. So we'll see how she does.
The most amazing thing to me about her, she's never felt any pain. She's like, as you couldn't, she was like, what happened? Everything is great. She was ecstatic. We're more than she is. She's done. I was so concerned about this lady, and she's done fantastically well to this point.
Hey, Sumit, do
She
you need
started off
gas at the end
LP.
of this case?
What's that?
Do you need gas in this case? I mean, you have a full vit, you got a big hemorrhagic buckle effect, and the brakes are well supported. Do you trust her pump? Can you just get out without gas or minimal gas or
Yeah, I mean, it's a
air?
great question. I don't know the answer to it. Thankfully, my end is very low on these because they do definitely make you sweat. But yeah, it's not unreasonable to do a shorter acting gas. The question is how these form very quickly. Could they be gone just as quickly the next day? It's possible. I doubt it. I think these are going to be there for a couple of weeks at least, and you may be even coming back to drain them. I'd still probably do gas.
I think the 93-year-old pump was my
Yeah.
concern, and so that these are, we're having these discussions dynamically as we are here, which is great. I think Leanne and I are reliving this conversation as we're talking out loud during it, and it's great to operate with fellows, and it's great when these has complicated cases, we're all using our brain together, and even though I'm older, it's great to hear ideas and such. I actually called Kaiser was next door. I called Kaiser in the room and said, anything else you would do different? So we just all sat there and kind of talked it through, and these same steps, and we just came to the conclusion, as everyone else did, like, let's try to get out. I decided on C3F8. I thought it made sense to me just from a expansion profile. I thought we could handle the pressure okay. And it's interesting. And unfortunately, it's more than one on this, like these type of cases, Sumit. And I've been surprised. If you can control it, I don't think you come back necessarily and drain these corridors.
Mhm.
A lot of these
I think
will
they do
resolve
okay.
on their own. Yeah, a lot of these will resolve. Not all of them, but a lot of them.
Yeah.
But well handled surprise, Leanne. Good job.
Well handled
Thank you.
surprise. All right, really great comments coming through the chat, so keep them coming. We'll try to address them. Charles, are you up? Ready?
Yeah, you guys can hear me okay?
Yeah. So our next presenter is Charles DeBoer. Charles is a second-year retina fellow here at Stanford. He did his residency at the University of Southern California. And happy to announce that Charles will be joining our faculty at Stanford this summer. So all of the toughest cases that no one is interested in doing will go to Dr. Charles DeBoer. Charles, take it away.
All right, perfect. So this is a case that we did together. I did this with Dr. Marthinjay. So the patient was a 61-year-old male and had a history of CNS lymphoma and panuveitis, and was referred to us for right eye vitritis concerning for lymphoma. The patient had a series of rituximab injections and minimal response. The patient was currently treated with topical steroids as well as eye-lowering medications. So in terms of the cancer history, basically was diagnosed with prostate lymphoma in 2009, had chemotherapy and then with remission, and then CNS lymphoma in 2015, got whole brain radiation, and then started developing vitritis of the left eye. Had a diagnostic vitrectomy in 2018, and then basically had a series of 3 recurrences treated with rituximab and radiation as well. To complicate things, the patient had uveitic glaucoma as well and had a micropulse CPC. Given there was a recurrence of CNS lymphoma, the patient also had a bone marrow transplant in 2021. And from there, basically the patient had this recurrence, but this time in the right eye. They had these 6 intravitreal rituximabs. They had done a cataract surgery. This was referred to us outside and to clear the view for a possible diagnostic vitrectomy. And this was a complicated surgery, complicated by anterior rent, and the patient was left aphakic. Vision in the eyes is poor, the left eye partially from the uveitic glaucoma. Most recent screening in terms of MRIs and PET scans were all negative for systemic disease. So the patient came to us, bare hand motion in both eyes, with elevated intraocular pressure in the left eye to 43. And the right eye was aphakic with an opacified capsule. And there was a cell as well in the back. So and if you look at the ultrasound here, you can see in R10 and T10, you can see that there's vitritis, but you can also see this like retinal thickening as well. So we don't have a great view to the back. And so the thought here is to go ahead and move forward with a diagnostic vitrectomy of the right eye, and to get a good sample to kind of help with this diagnostic dilemma. So we started both eyes. What we wanted to do is we wanted to get samples from the aqueous because there was a little bit of anterior chamber cell in the left eye as well. So we sent both AC samples for MYD88, and then we're going to go to the back of the right eye. And the thought here in terms of the right eye is we want to get a good sample, and a lot of times we'll do these diagnostic vitrectomies under air because you can get a larger sample, the eye doesn't collapse on you. But here we're aphakic and we have this kind of opacified lens capsule. And our consideration is if we go to the back with the, if we open up the lens capsule, then the air is going to come to the front. And so we're kind of challenged with a difficult view either way. But we know at this point there's no retinal detachment. So we basically have the ports in, and we have the cutter illuminated with the light pipe as well. And we're going to try and get a good sample here as well.
Hey, Charles, can I ask you a question?
Yeah.
So, you already know you have really strong evidence that this is lymphoma, right?
Mhm.
It's everywhere. Your view is pretty poor. You have probably amazing pathologists. Why not just do a pure diluted specimen so you can have really good control of the eye and the fluidics of this? Because it probably matters less about, you're already really suspicious. The cytology is probably going to be positive for you. So, at this point, air is just making your life harder?
I mean, I think that's a great question in terms of, that's one way to do it. We do like to, it's nice to have like a straight vitreous sample for our pathologist. And given the fact that there was a negative test, they basically had a negative biopsy of the left eye, we thought we could reasonably safely do this, but I don't think that would have been wrong at all to basically do it under fluid and give them a diluted sample, because we would have a lot of sample. I think that's a good point.
So have you
Why
ever
didn't we
talked to
just choose-
pathologists how they actually process these samples? Because when I talked to ours, they said they spin them down, and it doesn't matter if it's diluted or undiluted for the small samples that we're doing, that it doesn't make any difference to them. And once I heard that, I stopped doing the undiluted sample thing. I just do a straight turn on the infusion, take a good first sample and send that. And my positivity rates haven't changed in any way, shape, or form.
Yeah,
So I think this
agree.
significantly increases your risk.
Okay. Thanks for the comments. So we're going to get this on, pure vitreous sample, and then we're going to open up the capsule and we'll get our dilute sample as well. And we're going to send the vitreous here for MYD88 testing as well. So as we go to the back, I was kind of surprised at what I see, because this is not what I was expecting to see. Here superiorly, you can see that there's some, it's almost more retinal whitening. I was expecting to see kind of more of the, kind of like creamier white lesions, like subretinal lesions. But here we kind of have like these areas of hemorrhage. And then also like inferiorly, we have all of these snowballs. So to me, this was sort of surprising and not as common, for a lymphoma type picture. At least it gave us a little bit of pause. And this patient had 6 intravitreal Rituxan injections as well. So this was kind of this was at least concerning for us. And so at this point, we broadened our differential as well. And like one thing that you would think about could be like a retinal viral retinitis, right? Because that can exist as well.
So when in this scenario, as you're thinking about this, walk me through. Are you thinking about any potential retinal biopsy? Given this, or what's your threshold at this point?
Yeah, I mean, we had talked about doing a retinal biopsy. We did think that we had a good sample. Like we thought that we had a good vitreous sample, and we thought that that was going to be like the way that we had collected it. We felt that that was going to be adequate to for our pathologist. But I think if we didn't feel like we had such a good vitreous sample, I think we would have considered biopsy definitely. Here we didn't think that we thought we had a good enough sample to proceed without a retinal biopsy. it's definitely
Yeah,
something we
Danny-
could discuss.
Danny Memo, who's our fellow who joined us, has put together our series of this. And what we have found is once the retina is involved, there's actually there's a decent number of these that will be vitreous biopsy negative. Yeah, despite this. Now we don't do MYD 88 here. We are a cytology based place for making our diagnoses. So we admit our faults. But we have kind of shifted once we see kind of subretinal involvement or retinal involvement, we tend to go for tissue. That's been our mode here for the past couple of years.
The impetus for this was I had a case a few years, about a year and a half ago now, probably, where we had a guy came in with rip-roaring vitreous involvement with just a small area of subretinal involvement. And I just did the vitreous biopsy thinking, oh, if it comes back negative, I'll have him back in a week and take the subretinal. And unfortunately, in the next week, because the vitreous came back negative and because all the cells were necrotic, when he came back a week later, he, on the way in, passed out driving in and was taken to the ER instead with massive brain involvement at that point. And by the time we got back into the eye, it looked like this, with hemorrhage and big subretinal lesions. And we actually, I did another vitreous biopsy and a subretinal biopsy. The vitreous came back negative and the subretinal came back positive the second time around. And so I've switched. I do what Sunil does now. I should just have listened to him the first time, but now I actually will take I'll take a cutter and put it in the subretinal space and take a small piece of the subretinal at the time of the initial, if there's any retinal involvement. This plus what Danny's shown, he's going to publish this soon, hopefully. He's supposed to be submitting it, right?
We've got some
Yeah, I'll
good,
get her
good
tomorrow.
questions in the chat too. Someone asked, in terms of thinking of differentials, or a chance that this could be toxicity from intravitreal rituximab, like a HORV-like picture. Obviously, you've mentioned viral, or is this just a manifestation, subretinal manifestation of the lymphoma? So I guess walk us through your thoughts on differential and what, if anything, you'd have done differently based on how you're kind of processing what you're seeing here.
Yeah, I mean, I think that's a good point. In terms of the differential. I mean, the top thing is we know that lymphoma can masquerade. This is can masquerade as like a retinitis type picture. So that's definitely on our differential, especially given the history. The snowballs are not quite as consistent with it, and definitely without having our anything back. Viral is probably one thing that we were definitely concerned of. And felt something that we might want to treat, because it's something that you can treat with Foscarnet. And so that's one thing that we ended up doing for this case. I think a HORV type picture, I haven't seen that with rituximab, but that's also a good thought.
One of the things we could have done, which we didn't, is we probably could have gotten an intraoperative OCT at the time just to assess, where the level of disease was. If this is all just retinal, whitening and swelling, then that would be one thing. But if we saw subretinal deposits, then that would help us. We're also concerned that there was what looked like a serous detachment. We didn't see any breaks, but now you're going to go in and stick a needle cutter or take a piece of this out, and then you have a much more complicated situation. I think Charles is going to maybe show what made things a little bit dicier at this point with the.
This is
highlight.
a challenge. These are challenging cases. This is a lot of Monday morning quarterbacking here. I will admit it 100%. When you having walked into these scenarios, I think it sounds like you guys are thinking it through. I think the question is, how do you make the diagnosis at this point? And obviously you do no harm or as little harm to the eye. I would argue harm is coming to this eye if you don't get the diagnosis.
Harm
right?
is here.
Right, because you're
happening.
like, it's foveal threatening, whatever this process is. So to your point, Prithvi, of like turning an exudative to regmatogenous, okay, I mean, if it gets me the diagnosis, maybe we have to,
Yeah, keep rolling the tape, because there's another discussion point coming up here.
Yeah, so now we have these, so we've kind of lifted up a lot of the highlight, but you can see there's snowballs and some highlight out here. And, one of the things we were deciding is how much of this to try and remove. We already have a good tissue sample. We wanted to remove as much as we could safely do it, but this was like something we were discussing as well. And we use the flex loop, we use the ILM forceps to remove some of these snowballs. But we had talked about during the case, and I think you could go either way. We felt like we could do it safely, but we kind of had a low threshold to stop here. Because at this point we do have, we've cleared up a lot of the central opacities and we sent our
So
samples
do
off.
you think you got the hyaloid off in this entire case, Charles?
Well, that's a good question. Like you can see, we lifted from the nerve, but we never. I mean, like over here, it looks like there's still like some hyaloid that's down, which is kind of what we're trying to peel.
Yeah, I think we got the inferior 180, but then the
Yeah.
hyaloid was skiddic, even though we didn't think it was based on the ultrasound, and it's probably plastered on top of that necrotic retina up top. So that was the other concern. If we go and make holes in this eye, then the hyaloid's still on, and that's no good. So in this case,
This keeps getting better with you. This gets you're surprises. You have surprises on top of surprises.
I was like, we'll be done in 10 minutes. This is gonna be easy. Get our answer.
So we're basically removing kind of where we feel it's safe, and then we're going to shave kind of also once again where it's safe. Obviously not on the involved retina.
So would you all have tried to treat that fluid? Like, would you have tried to drain the subretinal fluid? It's right in the macula. Big bubble of it.
If you're telling me it's exudative and you're not going to take a sample, I'm getting out.
I think it's
That-
exudative. I mean, I couldn't.
Well, I mean,
it's possible there's micro breaks somewhere, but I don't know.
Charles, is there a way you could prove to me it is exudative versus regurgitatus? And if you want to ask you the question, I will.
Yeah. I mean, you look for shifting fluid. That's one of the ways to tell.
You could also put, if you wanted to, perfluorine in the eye and see if you can tamponade a break. There's fluid that shifts with the perfluorine, and then take it out. And I use that oftentimes for some of these uveitis, like when I'm trying to figure out if there's an exudative detachment or not. And I find it's very helpful for me. But it looks exudative, right? From everything you're showing me, you didn't see Schlerin come around at all as you're doing your vitrectomy. So I don't think I would treat the exudative process unless you're going to inject something in the eye and treat the disease. And I think the exudative process hopefully gets better.
And so pretty much here, so we shaved the periphery and then we closed the case. And post-op day 1, we gave foscarnet. The patient was started on valacyclovir. Here's our pathology. So our pathologist went through the slides, and you can see there's kind of large nucleoli, some with multiple nucleoli. There's apoptosis of these cells, and you can see they're large, kind of irregular. Because we're trying to figure out, are there inclusion bodies, something that might push us more towards like a viral. But our pathologist felt that this was very consistent with recurrence of the lymphoma. But on our postoperative week 1 OCT, you can kind of see sort of what we're seeing in the surgery as well, kind of sort of a diffuse involvement. PCR has been negative so far. MYD88 was negative in both eyes. PAX5 BCL6 positive, and then the flow cytology was CD19, 20, 22 positive. Right now, vision's LP, pressures are low. The patient has micropulse CPC or a full CPC of the left eye since we last saw them, and the pressure, and we started on max drops as well. So the pressure is being better there. But now we kind of have, in this post-op week 1, we kind of have this worsening, what we believe to be an exudative retinal detachment, because it sort of shifts like, an exudative type process. But the plan for right now is we're starting our intravitreal rituximab and methotrexate, and we're going to work with the oncology team to kind of come up with the next steps.
I've had cases like this with exudative detachments and this much involvement, and methotrexate does an amazing job of stopping this process. Unfortunately, the eye is done. I don't think you're getting much more vision. By the time you get an exudative detachment and this much of the superior retina involved, the vision's not going to recover. You have ischemia through the fovea, but you'll get rid of the eye will be more stabilized, but this will respond to your methotrexate. And if it doesn't, the only other option you have is radiation. But I find that methotrexate works for this. I'm not a fan of rituximab, as you can tell from my tone. I never think it works. I think methotrexate is far superior.
Yeah, this is rituximab monotherapy that was employed, which you know, I think I've always used it in combination with methotrexate, not as monotherapy. So, you know, it could have been that this was slightly undertreated in the beginning, but again, I think the view was really bad and you couldn't monitor the disease, and that was part of the problem here, is that capsule just opacified so much. One of the concerns, you know, we thought about taking the capsule first with the cutter, you know, with fluid or without. But the concern is some of those capsule fragments could end up in your cytopath, and that can sometimes lead to a confusing, like, alternative diagnosis. So we didn't want to muddy that up and, you know, try to flush it out and whatnot. So that's why we did this slightly risky, you know, get something first under air and then switch it, open the capsule, then be more thorough. But that capsule wasn't there. I think we could have, you know, kind of hit the task much easier. I'm not sure why I would have just taken the capsule in the first place when I took the cataract out, but that's different.
You didn't do the cataract surgery. That's fine. Great case. My God, holy cow. You guys don't make it easy for the fellow.
Thanks so much.
I think
All
we have
right,
one more
so,
case. Oh wait,
yeah,
before we do that, when's our should we
No, we can't, and we have to have all the announcements until Heidi.
Oh my God,
Otherwise,
okay.
everyone will log off. And we can give them all the announcements. But you know, we gotta have Heidi. Heidi Kakor is batting cleanup. It seems like he always bats cleanup for Cobra. Heidi is one of our second-year fellows, and is going to be presenting another surgical surprise. Heidi, you still on? You still awake, buddy? Heidi, are you on mute, buddy? Heidi, it's been 2 years. You figured out the mute button yet?
Still no audio.
Still no audio.
No.
So maybe we'll talk about the next Cobra rounds as Heidi walks through his. Maybe we should do this mine. That would be amazing. That would be fantastic. And we have now 90 people giving you IT support.
Yeah, perfect.
So we are going to do our next rounds on May 1st, and we hope to see you there. We'll probably be I think, but that's going to be our last one of the year, Prithvi. Or we're going to do one more.
Yeah, for this
It might be our
academic,
last one. We might hold our fellows back, depending on how this Heidi's thing goes here in a few minutes. But we may do one before the end of the year. But I think that's before the end of the academic year.
Yeah, and then but looking forward to our live Cobra rounds, which will be the Friday of the American Academy of Ophthalmology. So after the first sub-day session, so in San Francisco, at some marginally clean and cool place, I'm sure. But
it'll be a fantastic time. We had a great time this past year. Heidi, do I hear you're on?
Prithvi's house. Ayo.
Come on over.
Yeah, so you guys hear me?
Yeah, there you go, Heidi. Are you in a tunnel somewhere?
All right. No, I don't know what's going on. It's in my bedroom. I don't know what's going on with my microphone. So
okay, that's too much information. Thank you, Heidi.
No. Oh, here we go. Okay, so here. Can you see my PowerPoint?
Yep.
So, surprise case. Case summary: he's a 61-year-old gentleman with a history of rheumatoid arthritis and Crohn's, well-controlled on methotrexate. He was referred to our service for an IOL dislocation in the right eye. He complained of a large gob in his vision. He has a history of uveitis, as I mentioned, from his RA and Crohn's, IBD, but also he had optic neuritis from these conditions, resulting in optic atrophy in both eyes. He had cataract extraction in May 1985 due to frequent steroid use. Strangely enough, he was actually left, I think it was aphakic at the time, until he received vitrectomy to pick up some lens fragments actually in each eye. He got a focus lens in his right eye, and he got a ACIOL on his left eye. The eye, so of course, the eye that has the IOL dislocation is the right eye that had the sulcus lens. He's 2500 in the right eye. He has a little bit of band K. Very poorly dilating pupil. And it's hard to see really what's going on with this lens, but there's something floating. And he's avitretic, of course, from his previous surgery, his pallor in his nerve, and there's a tough view in the periphery. So the plan then was to say, okay, well, if we have a dropped lens, can nurse get it out? Either we give him a scleral sutured lens, or we'll do an ACIOL. And so I'm going to show my video now. And hopefully that's visible.
Yep, we can see it.
Good. So we set up, we do the paradigm, we set up and mark as if we're doing a sutured IOL with our plan for the time being. So we set up with our trocars where we're going to suture. And we get into the posterior segment, and you can see my cutter going through what should be the lens. We thought this was a Sommering, and you see our cutter going through it. So my question at this point, immediately after entering the eye, is where's the lens? It's just a Sommering ring, looks like. So we say, let's get a better look at things. We put in iris hooks, and I'll show you that we have a sulcus lens, slightly dislocated, I believe this is nasally here. And we see a Sommering that has the remnant of the capsule has fallen away. So it's actually not a dislocated IOL, it's a dislocated Sommering at this point, which of course changes the plan.
So it's hard to see the IOL at this point, Hadi. So is the IOL stable?
So the IOL does appear stable. It does appear in the right location. And I don't know if I can show it to you any better.
Oh, there we go. Now you can see it. Yeah, you can catch it on the
you can
edge
actually
as
see
you're
it
cutting.
here a little
Yeah.
better, or you can, yes, a minute ago. So I guess we can stop here and say, I mean, if you have a dislocated Sommering, this thing is brunescent, it's very tough. What would the plan be for the attendees on the call tonight? Would you just knock it back and leave it there? Would you try to get it out? Would you think you have to remove the IOL to do it?
Where's the capsule?
So there is it's really hard to visualize, but it's a 3-piece IOL, and there is it appears to be a little remnant of anterior capsule that is supporting it, but somehow the posterior aspect with the Sommering has fallen back. Is what we think is going on.
Yeah, it's shocking to me that lens isn't in the back of the eye. Like, I think that would be so the dream scenario is you get the Sommerings out and you leave the lens and you don't have to fixate a lens. But I think that my concern would be if we did that, which seems like it'd be relatively straightforward, that tomorrow the lens would be in the back of the eye. So I'd be scared about that.
So we kept on pushing on the limbus, trying to see if we could dislocate this lens. And
You're
this
trying
lens,
to dunk it? You're
I
trying to
don't
dunk
know
it.
because as Hadi and I are in this case where I'm asking him, how is this physically possible? Is my lens anatomy incorrect that we have a dislocated Sommering, but we still have an anterior capsule? So I had the same concerns that everyone has here. It was fascinating.
Were you was
the
this
haptics
sulcus
embedded in the
fixated? Was
ciliary?
it like, yeah, sorry.
Yeah, I was gonna say, are the haptics embedded in the ciliary body? Like where?
Hadi,
How is this
where
sitting
are the
there?
haptics?
So
Remember?
the haptics, it didn't seem to be in the ciliary body. I mean, it's hard to know. I mean, it must be somewhere in that region. Of course, we didn't do an UBM in this case before going in, so we don't know for sure. But I mean, as Mustafa mentioned, we were kind of all around just posterior to the limbus trying to visualize this. It was challenging to visualize the end of the haptic. Of course, it was all the way out there, and the risk was that if we try to find the answer, we might get a different outcome. We might end up dislocating the lens for sure.
One of the important lessons I've learned is if you can, he had his surgery done here 12 years ago, and I was able to get the old operative report. Anytime there's a dislocated IOL or an IOL case where you can find a report, read it, and one of our partners here did it and put an MA60 in the sulcus. That's what was said. It was not scleral fixated.
Correct.
So how would you take it out, Hadi?
So at first, I'm gonna try, even though I know it's kind of futile, to break up the sommering and get it out, but that plan didn't last for very long. I was able to take the sommering and kind of break it in half at a weak point. First of all, to get it down to the back of the eye, I think I got a couple of pieces away from it, but then there was this big brunescent piece you see here. So
ask everybody how would they take it.
Sorry?
No, I was gonna say that I think you're gonna ask everybody what they would do next, right?
And the chat
Yeah, so
consensus
what
seems to
that's
be
the
frag
question.
or
What
take
would
it
you
out like an ILFP.
Will you frag it? Do a cut down on the sclera? What are the plans here? We discussed all of this with Dr. Srivastava and I, but we'd love to hear if there are any what the ideas are out there.
I think it's getting too late at the night. So I heard frag or treat it like an ILP. What'd you decide to do?
So we decided not to frag this, and upon looking at the dislocation of the sulcus IOL, we tried a few different ways with the soft tip to bring it up to the AC. We felt that if we could bring it to the AC, we could get it out of a clear corneal wound. 3mm wound. So, and we said, if the lens falls, the lens falls, and we already set up for a sutured lens situation. If it falls, better fall now with us. Was this kind of manipulation that then later on, as was mentioned. So after a little bit of trial here, we figured out if we use the cutter, because of its suction on the side, I was able to kind of finagle it and rest it on the IOL. Removed one of the iris hooks to facilitate its maintenance in the anterior chamber of the eye, and then getting it out of the eye was another story. It was a little bulky. We used these. I forgot the name of them. They were the Machimer forceps or something.
These are the Machimer forceps, man. This is an IOFB.
Yeah, so it's an IOFB turned, ACFB, and so we right there got it out of the 3mm wound, and we got into the wound, and then getting it out was the second step of that. But luckily, with some viscoat and determination, able to safely remove the pieces of the sommering, put our iris back in. A couple of these chunks came out too the similar way, or if they're small enough and soft enough to your E10 crisscross wound to close up and close up our incisions and got out of there. Patient was extremely happy with the result. He felt that his blob was gone. His vision has been around where he started, about 2,500 because of the optic atrophy. But he was very happy given the disturbance and his vision was gone. And he's been doing well since. He was just seen a couple of weeks ago.
That was incredibly disrespectful of the anterior lens capsule, but fantastic. So a couple of questions that came up is, did you just consider taking out one of the 7 trocars you put in the eye to start with and just enlarge the wound with a MVR blade? Would that have been, if you're going to use the foreign body forceps, would that have been easier?
Yeah, we definitely discussed that. It would have required fairly large wounds. I think we thought it would destabilize things a lot with the eye and bring us to some considerable amount of risk. And if we weren't able to get it out, we should at least try through the anterior chamber and get it out through a corneal wound. If we can do it, then fine. We'll cut down if we can cut down. These things tend to be kind of awkwardly shaped. You have to get the orientation just right to get it out through a nicely shaped incision. Otherwise, it was the circumference of the diameter is one thing, but then the length of it is another. If you don't get it the right way, you get stuck in the wound and you're fighting with it, and then it can turn something that's an easy idea, easy plan can turn kind of challenging.
And we didn't anticipate needing the 20 gauge for the IOP forceps in the anterior chamber we thought this thing would just, we'd be able to burp the wound and have this thing pop out, but it was challenging. And I've had really challenging time fragging Sommering's ring. I know it's come up on the chat. I find it really difficult on some of these, and the amount of power it takes. It doesn't work as well as I thought. Maybe I'm just using it wrong, but I have not been very successful with treating these. This has been there now 30 years. Is that what we calculated, Hadi, for this guy? Because he had his phaco done when he was in his 20s or 30s. And every time I've handled one of these dense Sommering's ring, with a frag in the past, I just haven't been successful. That's why it was either enlarge the wound, but Hadi really thought we could sneak it through the anterior chamber. I was like, let's give it a go, and we put enough viscode in, and I didn't anticipate needing IOP forceps, but it was a interesting solution and worked well.
Did you put iris hooks back in? Because you mentioned that you went and got more pieces and then also came back to the front. So did you go like in and out with the iris hooks?
We didn't replace all of them. We replaced some of them back just to kind of get enough of a view to get things back, and we left that kind of supro-temporal quadrant where I was kind of had my access open, so we could facilitate that.
We used one as a ledge. One part of the iris as a ledge to hold it.
Yeah, that's a great,
right.
great outcome.
Temporal iris hooks as a ledge.
Yeah, in hindsight, I think MVR blade IOFB would have been much simpler, but would have been way less cool for Cobra rounds. So
We wouldn't have shown it on Cobra. It'd have been rejected.
I 100% agree with everybody. We would again, we didn't think we would need. We thought we could get this thing out relatively easy, but it was more challenging than EC. I think enlarging the scleral wounds would have been a very nice solution too.
Well, it would also have the issue of if you tried to get it out to the scleral wound that you enlarged, and then suddenly the IOL fell, and then
that's what we were thinking.
You're like, you were just waiting to put those Gore-Tex sutures in there.
And that's part. I was thought about making another another sclerotomy to get it. And the thing we talked about in the beginning was we were looking at the sclera if he was thinned enough, because he has a long-standing history of uveitis.
Yeah.
And RA, whether or not he had any scleral thinning. He looked a little thin, but he wasn't too bad.
Very nice.
On time, Prithvi. On time.
Look at that. Never happened. So Hadi, Leanne, Charles, Karen, fantastic cases. So in this surgical surprise for the fellows, we talked about relatively straightforward cases. We had diabetic traction detachments. We had a detachment that led to choroidals, a lymphoma diagnostic vitrectomy, and a IOFB, and all required some on-the-spot thinking as you go through. So I think preparation is the key in all these cases, because you have to expect the unexpected. But I think these 4 fellows did a fantastic job. Sunil, last words?
Great times, great learning lessons for everybody. I agree with those ideas that you had there, Prithvi. And I thank you to our attendings, both Steve and Sumit, for moderating the sessions. I thought it was a great time. Once again, thank you to going to be May 1st. Thank you to the iVista team for setting everything up. Bausch & Lomb for their continued support of Cobra. If you have any complaints, suggestions, please send them to Prithvi. If you have any compliments,
I will forward them to Sunil.
Please send them to me. And it should be fun on May 1st, and we hope you can join us then. Have a great night, everybody.